Alright class, our next lecture is going to be about thrombocytopenia and different types of thrombocytopenia. So what is thrombocytopenia? So by pure definition, it's a reduction in the number of platelets below the average range of 150 to 450. It occurs as a result of a destruction of platelets or as a result of decreased production of platelets by the bone marrow. It's not a disease, but rather can be a complication of other disorders, such as DIC, HIT, ITP, and hemophilia. So the normal hemostasis, or the normal stopping of blood, involves the vascular endothelium, platelets, and coagulation factors. They function together to stop hemorrhage and to repair vascular injury. A disruption of any component may actually result in bleeding, or it could result in thrombotic disorders. Again, thrombocytopenia is going to be a reduction of platelets below 150,000. Acute, severe, or prolonged decreases from this normal range can result in abnormal hemostasis that manifests as prolonged bleeding from minor trauma to spontaneous bleeding without injury. Platelet disorders can be inherited, but the vast majority are going to be acquired. Commonly, these acquired ones come from ingestion of certain herbs or drugs. Herbs include garlic, ginkgo biloba, I can never say that right, and ginseng. Certain drugs will include myelosuppressive drugs like chemotherapy agents, antibiotics such as the penicillins, and NSAIDs or aspirin. So the case study that we look at here is RH is a 46-year-old cancer survivor who returns to your clinic for a regular checkup. She's currently reporting an increase in fatigue in the last 2 to 3 weeks. She is unable to complete her normal morning ADLs without intermittent periods of rest. What should you do first? Here I would definitely say just get a good set of vital signs on her. Start to ask her those initial questions about her functional health patterns, her past medical history, especially knowing that she's a cancer survivor. Maybe understand and know when her last chemotherapy was or radiation, and keep getting a good history and picture of her that way. Then you can go through and do your assessment and find other factors. We already kind of mentioned this, but the inherited causes of thrombocytopenia, that's going to be your hereditary form. The acquired causes I already mentioned, but these are the actual diseases represented. So immune thrombocytopenia purpura or ITP, thrombotic thrombocytopenia purpura or TTP, and then heparin-induced thrombocytopenia or HIT. There is also disseminated intravascular coagulation or DIC that we talk about in a different PowerPoint. Other acquired forms are also going to include leukemia, lymphoma, and myeloma. So immune thrombocytopenic purpura or ITP. It's the most common acquired thrombocytopenia. It's a syndrome of abnormal destruction and reduced production of circulating platelets. It was originally termed idiopathic thrombocytopenic purpura because its cause was unknown. However, it is now known that ITP is primarily an autoimmune disease. In ITP, platelets are coated with antibodies. Although these platelets function normally, when they reach the spleen, the antibody-coated platelets are recognized as foreign and destroyed. Decreased platelet production contributes to ITP. When you look at a peripheral blood smear, usually these platelets appear very large because they have platelets coating them. They have antibodies coating them. And generally speaking, when you see ITP, they have a very low platelet count. So keep that in mind as we continue through. The clinical syndrome manifests as an acute condition in children and a chronic condition in adults. Chronic ITP can occur in women between 15 to 40 years of age or older individuals. Chronic ITP has a gradual onset and transient remissions may occur. Multiple therapies are used to manage the patient with ITP, such as corticosteroids, splenectomy, and immunosuppressive therapy. Next one is thrombotic thrombocytopenic purpura, or TTP. TTP is an uncommon syndrome that's characterized by hemolytic anemia, so destroying RBCs as well, thrombocytopenia, neurologic abnormalities, and you'll see why, fever in the absence of infection, and renal abnormalities. Not all features are always present in all patients, but basically what happens is microthrombi deposit in arterioles and capillaries, and that's because you end up bleeding and clotting simultaneously at the same time. And those deposits in those arterioles and capillaries can be in the kidneys, in the brain. I mean, they could be anywhere, but that's where you see neurologic issues, and that's where you see issues with the kidneys. In most cases, the cause of TTP is due to the deficiency of a plasma enzyme called ADAMTS13. This enzyme usually breaks down von Willebrand clotting factor into its normal size. Von Willebrand factor is the most important protein-mediating platelet adhesion to damaged endothelial cells. Without the enzyme, ADAMTS13, unusually large amounts of von Willebrand factor attach to activated platelets, thereby promoting platelet aggregation. So essentially, they clump together and this creates clots. But you're also depleting the platelets, you're aggregating them elsewhere. So platelets are clumping continuously in one spot, so they're all in that one spot, but then elsewhere in the body, there is no platelets left, or there are no platelets left. TTP is going to be your medical emergency, therefore, because again, bleeding and clotting occur simultaneously. When you have a patient that is in TTP, you end up seeing a lower hematocrit and hemoglobin, and that's that hemolytic anemia piece. You see a low platelet count, but it's not as low as it would be with ITP. And then on a peripheral blood smear, there's schistocytes, which we'll talk about on a different slide. The next one we're going to talk about is heparin-induced thrombocytopenia, or HIT. So one of the risks associated with the broad and increasing use of heparin is the development of this life-threatening condition called HIT. In HIT, essentially, platelet destruction and vascular endothelial injury are the two major responses to an immune-mediated response to heparin. So platelet factor 4 binds to heparin. This complex binds to the platelet surface, leading to further platelet activation and the release of more PF4. This creates a positive feedback loop of this entire complex. Antibodies are created against this complex and remove them prematurely from circulation. Because of that, you end up with thrombi and platelet fibrin, you end up with thrombocytopenia, and you end up with platelet fibrin thrombi that form. So this is another one where you end up seeing clotting and you end up seeing bleeding simultaneously. HIT can develop usually 5 to 10 days after heparin therapy is started. Essentially, it's first recognized usually when the patient's platelet count has fallen 50% or more from the baseline, or if a thrombus forms while the patient is on therapy. Another response that you'll see is if the platelets suddenly drop below 100,000. Venous thrombosis is the major clinical problem. Arterial thrombosis can develop, DVT and PE can result due to the thrombis, and essentially you see more thrombosis here than you see bleeding. Symptoms of bleeding are unusual because the platelet count will rarely drop to below 60,000 microliters. So we're going to talk a little bit about some manifestations in general of most thrombocytopenias that you'll see. Most patients are asymptomatic. Mucosal bleeding might end up being, or cutaneous bleeding, the most common symptom. This can manifest as epistasis and gingival bleeding, and large bolus hemorrhages may appear on the buccal mucosa because of a lack of vessel protection by the submucosal tissue. Bleeding into the skin is usually manifested by petechiae or microhemorrhages, purpura, which are bruises from numerous petechiae, kind of in a cluster, and then ecchymosis are larger lesions that come from hemorrhage. An example of petechiae. Petechiae are small, flat, pinpoint, red or reddish-brown microhemorrhages. When the platelet count is low, RBCs may leak out of the blood vessels and into the skin, which causes the petechiae. When petechiae are numerous, the resulting reddish skin bruises, and it's called purpura. Larger purplish lesions caused by hemorrhage are termed ecchymosis. Ecchymosis, you can see them flat or raised, and pain or tenderness are usually present. So this would be an example of purpura. So some other clinical manifestations in general, again, we're talking here, are going to be prolonged bleeding after routine procedures, such as IV access, like when you insert an IV, or IM injections. Bleeding can be internal. If that's the case, it could manifest as weakness, fainting, dizziness, tachycardia, abdominal pain, or hypotension. Hemorrhage is a major problem and can occur in any area of the body, including the joints, retina, and the brain. Cerebral hemorrhage can be fatal. Insidious hemorrhage may first be detected by discovering anemia that accompanies blood loss. Because thrombocytopenia can be accompanied by vascular thromboses in some of these disorders, so for example, TTP and HIT, signs and symptoms of vascular ischemic problems can manifest, such as subtle confusion, headache, or other severe complications like seizures and coma. Because these symptoms can be subtle, astute and thorough assessments of the patients is essential. So I love this because it mentions a lot of the neurologic side effects related to thrombocytopenia. Super important to think about, and especially when we're talking about TTP and HIT, where those microthrombi can form and clog vessels or arteries in the brain. Diagnostic-wise, any reduction in the platelets below 150,000 may be termed thrombocytopenia. Prolonged bleeding from trauma or injury does not usually occur until the platelet count drops less than 50,000. When the count drops below 20,000, spontaneous life-threatening hemorrhages such as intracranial bleeding can occur. Examination of the peripheral blood smear may help distinguish acquired disorders such as ITP and TTP from congenital disorders, which may be indicated by abnormally sized platelets. The patient's medical history and clinical examination, along with comparison of laboratory parameters, helps to determine the underlying cause of thrombocytopenia. So, other diagnostic studies we can look at, there's laboratory tests that assess secondary hemostasis or coagulation, such as prothrombin time and activated partial thromboplastin time. These can be normal even in severe thrombocytopenia. Specific assays, such as ITP antigen specific assay or enzyme linked immunoassay for platelet factor 4 heparin complex for HIT, can be done to assist with diagnosis. In TTP, testing for the deficiency of that enzyme ADAMTS13 is not always diagnostic, so an increase of lactic dehydrogenase or LDH can help establish the diagnosis, and that's because you see an elevated LDH when there's ischemia from clots, so when you have those intravascular injuries. When thrombocytopenia occurs with anemia, characterized by altered RBC morphology, including spherocytes, schistocytes or fragmented cells, and pronounced reticulocytosis, a diagnosis of TTP should be suspected. So those schistocytes, what it is it's the RBCs have a helmet on them. They have a helmet shape. These findings are particularly a result of intravascular fibrin deposition causing a slicing of the RBCs. So kind of interesting there. Bone marrow exam is done to rule out production problems as the cause of thrombocytopenia, so that would be for your leukemias, maybe aplastic anemia, or other myeloproliferative disorders. Bone marrow analysis performed if other test results are inconclusive, especially in older adults, because of a higher suspicion of an underlying bone marrow disorder. When destruction of the circulating platelets is the etiology, bone marrow analysis shows megakaryocytes, which are precursors to platelets, to be normal or increased, even though circulating platelets are reduced. Specific blood analyses using flow cytometry and other techniques can detect antiplatelet antibodies as the source of destruction. When taking our patient's BP, you notice that she has small, flat, pinpoint reddish-brown microhemorrhages all over her arms. On further inspection, you notice that on her left thigh she has a very large purple bruise, which she reports is tender to the touch. So what are these? Well, the first one is going to be petechiae, and the second one is going to be ecchymosis. So our collaborative care for our thrombocytopenias in general is based on the underlying cause of the disorder. Removal or treatment of the underlying cause may be sufficient, and for any thrombocytopenic disorder, we should avoid aspirin and other medications that affect platelet function or production. So with ITP specifically now, therapy is indicated if the platelets are less than 30,000 or if the patient is symptomatic. Initially, you utilize corticosteroids. These will help suppress phagocytic response of splenic macrophages, resulting in an increased lifespan of the platelets. It also depresses antibody formation, because what do steroids do? They suppress immune system. It also helps to reduce capillary leakage. We can also see, again, because it's that autoimmune response, high doses of IVIG or anti-RHD, which is a component of IVIG. We can see those given. Those help compete with anti-platelet antibodies for macrophage receptors in the spleen. You can give IVIG or anti-ROD if the patient is not responsive to steroids, but steroids are definitely still used first. Rituximab is another option. This is lyse-activated B-cell therapy, and this is shown to, of course, reduce the immune recognition of platelets. And then a splenectomy can be done on these patients. It's indicated in patients who do not respond to other treatments. It can be done laparoscopically. And patients who have splenectomies and ITP, about 60 to 70% of them achieve complete or partial remission. So platelet transfusions for ITP, they're never used prophylactically, and that's because if you get platelets, you're just at risk of that antibody formation. They can be used to increase platelet counts in life-threatening hemorrhages. It could also be indicated if your platelet count drops below 10,000 or if bleeding is anticipated before a procedure. But I'm just going to flat out say it's very unusual to give platelets to patients that have ITP. If there's severe bleeding, there is this anti-fibrinolytic agent that can be used. It's called aminocaproic acid. Just another tidbit of information for you guys. So with TTP next, first try to treat the underlying disorder or remove cause, of course. Untreated TTP results in irreversible renal failure and possible death. That's related to those microthrombi. Plasmapheresis or plasma exchange is used to aggressively reverse platelet consumption. Essentially, it supplies the appropriate amount of von Willebrand factor in the enzyme ADAMTS13 while removing the large von Willebrand molecules that bind with platelets. Corticosteroids may be added to this treatment. Rituximab is used if the patient is resistant to plasma exchange inhibitory ADAMTS13 Ig antibodies. You can see sometimes with these patients a splenectomy or immunosuppressive therapy otherwise, definitely. But what I always point out here is there are no platelets given. We don't give platelets, and it's contraindicated due to the risk of increased clotting. So her lab results are back, and it looks like her platelet count is low. Her H&H is low, so that's interesting. Right there, your brain should be going off. Her PT, that's normal, 15 seconds. Her APTT is 35, which is also normal. The normal lab values for PT, are 10 to 15, and then APTT is 30 to 40. So what type of thrombocytopenia does she probably have? In my opinion, just from looking at this, I would think thrombotic thrombocytopenic purpura. And what gives that away to me is that H&H value that's decreased. So there's some kind of bleed, and her platelets are low, but they're not very low. She's not at risk for spontaneous bleeding, or hemorrhage rather. With HIT, collaborative care, what you do is heparin has to be discontinued when HIT is first recognized. So immediately you stop all heparin, including flushes. Like even if they have heparin in like a vascular catheter, you don't flush it. This also has to be noted very clearly on the medical record. Next, the patient is started on a direct thrombin inhibitor, and this is to maintain anticoagulation. Examples of this are lepirudin, argaritron, factor 10 inhibitors, and there's a bunch others. Coumadin should only be started in these patients when their platelet count has reached 1,500 again. Patients who have had HIT should never be given heparin or low molecular weight heparin, which is what Lovenox, ever again. Please make sure this is clearly noted on the patient's medical record. Now, if clotting is severe here, You can use plasmapheresis to clear platelet aggregating antibodies. You can also give heparin to protamine sulfate to interrupt heparin. Thrombolytic agents can be given for clots, or the patient may have to go for surgery. What do you think is a contraindication here? Platelets are a contraindication, and that's because of the increased clot formation around the body. So, acquired thrombocytopenia from decreased platelet production, care is going to be based on identifying the cause and treating the disease or removing the causative agent. So, these are those decreased platelet production ones. So, think about your leukemia, think about your lymphoma, other things that I mentioned in prior slides. You can treat with corticosteroids if the precipitating factor is unknown, and that's because, as you can see from the previous disorders, most of them can be treated with steroid therapy. Platelet transfusions can be given if the patient has life-threatening hemorrhages. As I mentioned on the previous slide, often this is caused by another underlying condition or the therapy that's used to treat that condition. So, for example, in acute leukemia, all blood cell types can be depressed. Chemotherapeutic drugs can cause bone marrow suppression. The thrombocytopenia usually does resolve in these patients if the patient is adequately supported during their treatment. So we said that our patient has TTP. So what kind of treatment would that be? We're going to try to use that plasma exchange or plasmapheresis aggressively to reverse platelet consumption. If she doesn't follow through with this treatment, she could have irreversible renal failure and death. And how will the doctor know when to stop her treatment? This treatment is done daily until her platelet count normalizes and hemolysis ceases. So back to, in general, thrombocytopenia again. Subjective data, you want to gather their past history, definitely know any medications that they were on, and know their functional health patterns. Objectively, look for fever, lethargy, bleeding, splenomegaly, abdominal distension. What can that be from? Can be from bleeds. And look at their laboratory data. We also have to think about health promotion. So discourage the excessive use of over-the-counter medications, especially those aspirin products. Encourage the patient to seek prompt medical attention for any symptoms of bleeding. We need to give vigilant nursing care for patients receiving chemotherapy drugs because, again, those are going to essentially induce thrombocytopenia in many patients. Acute intervention-wise, so we want to prevent or control hemorrhage. Bleeding usually begins superficially, but deep bleeding into the muscles, joints, and abdomen usually occurs only when clotting factors are severely diminished. You want to emphasize that a seemingly minor nosebleed or new petechiae might indicate potential hemorrhage, and the healthcare provider should be notified. Bleeding from the posterior nasopharynx may be difficult to detect because the blood may actually be swallowed. So you want to watch for bleeding such as that can be difficult to detect. Some other interventions, we're going to avoid IM injections, star that. If subcutaneous injection is unavoidable, use small gauge needles and apply pressure or ice packs after. And then we, of course, want to teach self-care measures to reduce the risk of bleeding. So that would be use of a soft bristled toothbrush, use of an electric razor, not a sharp razor. Do not pluck your eyebrows or other hair, and you should not be getting tattoos or piercings. Of course, we need to closely monitor their platelet count, but note that as bleeding occurs, red cell and coagulation factors are consumed along with platelets, so it's important to monitor all blood cell and coagulation studies. In women with thrombocytopenia, menstrual blood loss may exceed the usual amount and duration. Counting sanitary napkins used during menses is another important intervention to detect excessive blood loss. Blood loss of 50 mLs will completely soak a sanitary napkin. Suppression of the menses with hormonal agents may be indicated during predictable periods of thrombocytopenia to reduce blood loss from menses. So, for example, during chemotherapy or possibly during a hematopoietic stem cell transplantation. So, with our platelet transfusions, you administer them again for life threatening situations or bleeds. You can also administer them pre-op, if your patient's going to surgery, you're anticipating that they're going to need blood product support. Do remember that blood component therapy is frequently used to manage hematologic disorders and that you definitely need a physician order. You have to make sure that the physician has discussed the risks, benefits, and alternatives with the patient and that this is clearly documented in the patient's record. Blood transfusion kind of has a broader meaning now too, so we're talking here platelets, red blood cells, and plasma, because each can be given separately or they can all be given together in mass transfusion protocols. Do remember also that giving this blood component therapy is sometimes a temporary measure until we can actually fix the underlying issue.